Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Insight Corporation.
This program is presented by Medscape Education Global.
Welcome. We're here at ASH 2024, and we're going to do a data deep dive discussing the novel approaches in relapsed refractory follicular lymphoma. I'm Laurie Sen from the University of British Columbia and the BC Cancer Centre for Lymphoid Cancer in Vancouver, Canada. And I'm here with my colleague, Dr. Cami Maddox from the Division of Hematology at The Ohio State University. In today's program, we're going to be discussing some selected abstracts looking at novel and emerging therapies for relapsed refractory follicular lymphoma that were presented at ASH 2024. And we're going to be discussing the clinical implications of these data for the evolving management of relapsed refractory follicular lymphoma. So we know that follicular lymphoma is the most common indolent subtype of non-Hodgkin lymphoma, but it is a very heterogeneous disease. So most patients have indolent behaving disease, but certainly some patients have a more aggressive pattern of disease. In general, we have many treatment options. It is a very responsive lymphoma to treatment, but most patients will experience a relapse and remitting course and require multiple lines of treatment in their lifetime. And so for today, I think it's fair to say that our current treatments are not curative for follicular lymphoma. And of course, we know that in every patient, there also is an underlying risk of transformation to a more aggressive B-cell lymphoma that really needs to be considered as a possibility as they move on to every line of therapy. So although we have an increasing number of therapy options for patients with follicular lymphoma, there continues to be a need for novel therapies. So follicular lymphoma continues to remain incurable. Most patients will need to go on to a next line of therapy. And ultimately, what we're aiming to strive toward are tolerable regimens that induce long-term disease remission. And more specifically, I think in the bigger goal, we're looking to try and personalize therapy for follicular lymphoma, picking the right option for the right patient at the right time. So at ASH 2024, we saw a lot of data coming forward. We've selected a few of the abstracts that were presented, and specifically, we're going to be talking about the phase 3 INMIND study of tafasitamab combined with lenalidomide and rituximab for relapsed refractory FL. We're also going to be talking about an interesting combination of loncastuximab tesirine with rituximab in relapsed refractory follicular lymphoma. And we're going to be talking about updated data on the bispecific antibody epcoritamab with R-squared in patients with relapsed refractory follicular lymphoma. So to start, we're going to be talking about the INMIND trial, which was presented as a late-breaking abstract at ASH 2024. INMIND was a large phase 3 double-blind placebo-controlled international multi-center randomized study that included patients with follicular lymphoma grades 1 to 3A who had had at least one prior line of therapy and who had an indication to go on to their next treatment. All patients were treated with standard dosing of 12 cycles of lenalidomide combined with rituximab, but patients were randomized 1-to-1 to receive either the placebo or tafasitamab at 12 milligrams per kilogram intravenously for the 12 cycles. So both arms received the same duration of therapy. So the randomization was stratified for some relevant subgroups known to be of higher risk, namely patients who are POD24 or had progression of disease within 24 months of initial diagnosis, patients who were known to be refractory to prior anti-CD20 monoclonal antibody, and also for the number of previous lines of treatment being either one line or two or more lines of treatment. The primary study endpoint was progression-free survival as determined by the investigator. Additional endpoints included a confirmation of progression-free survival results by an independent review committee, as well as PET-CR and overall response, also overall survival and time to next treatment. So baseline characteristics were similar between the two arms. Most patients had advanced stage disease and a high-risk FLIPI score, and all patients had an indication for treatment, but about 83% had confirmation of meeting GELF criteria. Regarding prior treatment history, the median number of prior therapies was 1, and 55% of patients had had 1 prior line of therapy, and 45% had 2 or more prior lines of therapy. This was a relatively high-risk patient population, so approximately a third of patients had POD24. About 40% of patients were refractory to their last prior therapy, and 43% of patients were actually known to be refractory to prior anti-CD20 monoclonal antibody. So at the time of the data cutoff analysis, in which there was a median follow-up time of 14.1 months, the trial met its primary endpoint of improved progression-free survival by investigator assessment. Importantly, there was a significant improvement in progression-free survival with the addition of tafasitamab to lenalidomide and rituximab, where the median progression-free survival was 22.4 months with the tafasitamab and only 13.9 months in the placebo arm. And that represented a hazard ratio of 0.43 and a p-value of less than 0.0001. The progression-free survival was also confirmed by an independent review committee that also demonstrated very concordant results and a significant improvement in progression-free survival with the tafasitamab. A number of subgroups were looked at, including POD24 status, number of prior lines of therapy, and whether or not patients were refractory or not to prior anti-CD20 monoclonal antibody. We saw significant benefits in all of those subgroups, regardless of those risk factors. The trial also demonstrated that the addition of tafasitamab to lenalidomide and rituximab resulted in a higher PET-CR rate, as well as a higher overall response rate. Importantly, this also translated into a higher time to next treatment for patients receiving tafasitamab. At the time of analysis, it's still relatively early data to interpret overall survival, but as survival analysis was looked at, and at this time, there is a trend for improvement in the tafasitamab arm. In general, toxicity was relatively balanced between the arms. The most common any grade toxicity observed was neutropenia, with occurring in similar rates in both treatment arms. In terms of higher grade toxicities, again, the most common high grade toxicity was neutropenia. Importantly, the addition of tafasitamab didn't limit the delivery of lenalidomide and rituximab. So there was no difference between the arms and the requirement for dose delays or dose reductions. So what we learned for the INMIND trial is that the addition of tafasitamab to R-squared really resulted in a significant improvement in progression-free survival. And this really meant a 57% reduction in the risk of progression, relapse, or death. And this was seen across all of the pre-specified subgroups, including the higher risk categories of patients with POD24, those refractory to anti-CD20 monoclonal antibodies, as well as patients having received multiple lines of therapy. Right now, the overall survival data, as I stated, is immature, but there was a trend for improvement with tafasitamab. And the safety profile between the arms was comparable and consistent with what was expected with the individual agents. This is the first trial to actually validate the approach of combining two monoclonal antibodies in the treatment of follicular lymphoma, and here an anti-CD19 and anti-CD20. Tafasitamab combined with lenalidomide and rituximab can be easily administered in the community as well as academic settings and may represent a potential new standard of care for patients with relapsed refractory follicular lymphoma. So we're going to move on and discuss a few additional abstracts, and I'll ask Cami to tell us about other novel approaches.
Thanks, Lauren. So the first abstract we'll talk about is fixed duration loncastuximab tesirine with rituximab in relapsed refractory follicular lymphoma. This trial was a phase 2 single-arm, single-center investigator-initiated study with a primary endpoint of complete response at week 12 by Lugano response criteria. Secondary endpoints included overall response rate, safety and tolerability, 2-year PFS, and OS. This is the study design. Patients were treated with lonca at a dose of 150 for the first 2 doses, and then that dropped to 75 for the third dose in combination with rituximab weekly times 4. After that, they were reassessed by PET scan. For patients who were in a CR or PR, they went on to receive 3 more cycles of the combination, and those patients who had stable or progressive disease went off treatment. They were then reassessed again by PET scan. For patients who were in a CR, they went on to receive single-agent rituximab. PRs continued with a combination of lonca and rituximab, and stable disease or progressive disease went off of treatment. Looking at the baseline characteristics in these 39 patients, there were high-risk patient population. Close to a little over 60% of the patients were high risk by FLIPI. A little over half of the patients had POD24. Nearly all patients had high tumor burden by GELF criteria, and about a quarter of patients had bulky disease as defined by greater than 7 centimeters. Looking at prior treatments in this patient population, about half of patients were refractory to their last therapy, with the other half being relapsed. The median number of prior lines of therapy was 1, with a range of 1 to 6, and about a quarter of patients had received 3 or more prior lines of therapy. The majority of patients had received frontline therapy with chemoimmunotherapy, either with R-CHOP or bendamustine rituximab, but there was 15% of patients who just received rituximab monotherapy. Looking at toxicity of this regimen, so the most common all-grade events, cytopenias, hyperglycemia, increased ALP, ALT, fatigue, increased AST, and rash. There were also grade 3 neutropenias, and then 1 patient each with grade 3 hyperglycemia, increased ALT, and fatigue. Looking further at dose discontinuations and significant adverse events, there were 2 patients who discontinued therapy due to disease progression, and this was the most common cause of treatment discontinuation. These patients had large B-cell lymphoma on confirmatory biopsies. There were no treatment-related deaths during the study course, and 4 patients experienced related serious adverse events, which included cellulitis after loncastuximab extravasation, febrile neutropenia, dyspnea secondary to pleural effusion, and generalized edema. Looking at efficacy of this regimen, response at 12-week, over 97% of patients had an overall response, with 2/3 of patients achieving a complete response. Best overall response was the same, a little over 97%, with a little bit of improvement in complete response at close to 77%. Looking at response in these high-risk disease patients, this was a post-hoc efficacy analysis, but best overall response in patients with POD24 was 100%, with 85% having a CR. Best overall response in the high-risk FLIPI patients was 96%, with 67% having a CR. In the prior transformed follicular patients, best overall response was 100%, with 73% achieving a CR. And best overall response in patients who had had rituximab and alkylating agent was 100%, with 75% of patients achieving a complete response. Looking at progression-free survival and overall survival, the 12-month PFS was 94.6, and the 12-month overall survival was 94.1. This regimen is being further evaluated in a multi-center study with a similar induction for the first 3 cycles. However, for patients who are responding, they are then only receiving 2 more cycles of therapy in order to limit toxicity. So with this, they concluded that limited duration loncastuximab with rituximab provides significant complete response rates in second-line and later FL with high tumor burden and POD24. The study did meet its primary endpoint with a week 12 CR rate of more than 50%. CRs appear prolonged with a 12-month progression-free survival of 94.6% and not reached with median PFS at the current follow-up. The safety profile in follicular lymphoma was consistent with prior studies in large B-cell lymphoma with no new safety signals. Most of the adverse events were grade 1 to 2, including hyperglycemia, increase in liver enzymes, fatigue, and rash. This study suggests that a fixed duration program of loncastuximab with rituximab is a promising combination in second-line and later FL. The next abstract looked at fixed duration epcoritamab in combination with R-squared in second-line relapsed refractory follicular lymphoma, and this came from the EPCOR NHL2 arm 2 of that study. The primary endpoint of this study was overall response per Lugano criteria, and secondary endpoints included CR, duration of response, duration of complete response, progression-free survival, time to next therapy, overall survival, and MRD analysis, and then safety and tolerability. In this trial, concomitant fixed duration epcoritamab was given with R-squared for up to 2 years. You can see the 2 different treatment regimens, with epcoritamab given weekly for the first 3 cycles, and then biweekly through cycle 8, and then every 4 weeks until discontinuation, and then given weekly for the first 2 cycles, and then every 4 weeks until discontinuation, with rituximab and lenalidomide given per standard. Looking at the baseline characteristics and treatment history, close to 60% of these patients were considered high risk by FLIPI, and nearly a little over a quarter of patients had bulky disease. Looking at treatment history, half of the patients had POD24 to any line of prior therapy, with close to 40% having POD24 to first-line chemoimmunotherapy. A little over a third were considered primary refractory, and the third were double refractory. Median time from diagnosis to first dose of treatment on this trial was 63 months. Looking at patient disposition and treatment exposure, so these patients were treated during the COVID-19 pandemic. There was a median of 22 epcoritamab cycles initiated. Epcoritamab did not affect the R-squared dosing intensity, again given cycles 1 through 12. The median relative dose intensity for rituximab was over 97%, and the median relative dose intensity for lenalidomide was greater than 80% throughout the 12 treatment cycles. Looking at responses in this, so deep responses were seen regardless of high-risk features. Best overall response was 96%, with complete response of 87%. Looking at the MRD analysis, of the 75 patients evaluable for MRD, 88% of them were shown to be MRD negative at any time point during treatment. Responses appeared to be durable, with the median duration of complete response and the median duration of response not reached. 93% of patients who achieved a complete response completed treatment per protocol, remaining in CR, and 81% of the patients with CR who discontinued epcoritamab treatment early due to reasons other than progressive disease also remained in CR. Looking at outcomes in the high-risk subgroups, including POD24 to first-line chemoimmunotherapy, patients who were primary refractory to any therapy, patients who were double refractory, or patients who had received one prior line of therapy, there were durable complete responses seen across these high-risk subgroups, with the best PFS observed in patients with one prior line of therapy. MRD negativity was associated with improved progression-free survival. Next therapy was not initiated for most patients at 2 years, and most patients remained alive at 2 years. Looking at safety, rates of neutropenia were consistent with prior reports of R-squared alone. Half of patients received G-CSF, including a quarter of patients who were treated prophylactically. There were 3 grade 3 febrile neutropenias, and like many of these trials, patients were enrolled and treated during the global COVID-19 pandemic, and this did result in 5 fatal treatment emergent adverse events of COVID-19. There were no other fatal adverse events related to treatment. There was no clinical tumor lysis syndrome events in this trial. The cytokine release, or CRS, that was seen, they saw primary low-grade CRS and ICANS with the double step-up dosing, and the timing of CRS was predictable. So 51% of patients had CRS, but only 2 patients had grade 3 CRS, and there was no grade 4 CRS seen. They concluded that with more than 2 years of follow-up in 111 patients with relapsed refractory FL, fixed duration epcoritamab plus R-squared continued to show deep and durable response, including in patients with high-risk features. The overall response was 96% and complete response was 87% in the overall population, with a notably higher CR rate observed in second-line follicular patients. MRD negativity was 88% and was correlated with the PFS. Estimated 21-month PFS rates were 80% overall and 86% among MRD negative patients. Manageable safety profile was consistent with previous reports, and no new safety signals were seen. Results support the ongoing phase 3 trial evaluating epcoritamab in combination with R-squared versus R-squared in relapsed refractory FL in the EPCOR FL1 study. Join Lori and me in the next chapter as we dive into the clinical implications of the latest data we just shared.
So we're going to discuss what really is an evolving paradigm shift of management in follicular lymphoma and the implications of recent data for clinical practice. We reviewed some select abstracts presented at ASH 2024. Namely, we discussed the INMIND trial of tafasitamab combined with lenalidomide and rituximab. We saw some early data presented on the combination of loncastuximab tesirine with rituximab, and as well some longer-term follow-up of epcoritamab bispecific antibody with R squared, both in relapsed refractory follicular lymphoma. So I'm going to ask you, Cami, to maybe think of this data in light of patients that you're treating in clinical practice, and how might the findings of some of this data impact what we do for patients in the clinic moving forward?
Yeah, so I think this is obviously some great data that we've seen here. Maybe I'll just kind of talk a little bit about, approach to treating follicular lymphoma that I use, and then how I see this potentially incorporating into that treatment. I mean, I do think you mentioned at the beginning that we want to reach a point for precision medicine in follicular lymphoma. And I think we're starting to do that, where we don't necessarily treat all patients the same, but really try to treat them both at diagnosis and relapse, based on the available therapies we have in the patient's disease and patient needs. Um, there's a lot of, frontline chemotherapy trials that are of interest, but I would still say that most patients in my practice who require therapy at diagnosis are receiving chemoimmunotherapy for, high tumor bulk or high risk disease. So then that takes me to, when these patients relapse, what am I considering for treatment at relapse? And that's where I really think the R squared regimen, I've taken advantage of that regimen a lot. And so I think looking at the tafasitamab NMIND trial, that was nice data to see. I think, that the addition of the tafasitamab antibody, which we're familiar with from relapsed refractory large cell lymphoma, showed improvement in outcomes when added to the R squared regimen. But really, if you looked at it, to me at least, the toxicity looks very, very similar. So adding an efficacious agent, but not really adding toxicity. So while we don't have an approval for that, I could see that more immediately impacting treatment-based decisions if we did receive an approval for that. I think it's interesting. I think R squared is kind of one of the more interesting things to combine things with, right? So the abstract looking at addition of epcoritamab, the bispecific antibodies are something I'm really using a lot in the third line setting. Both we have the approval of 2 bispecific antibodies for follicular lymphoma, and I would say in most patients I'm probably even using that prior to CAR T cells.
So I certainly agree with you that, right now chemoimmunotherapy is still probably, the standard frontline therapy that gets used as well in my own clinic. I think though in the relapse refractory setting, we know that chemoimmunotherapy does lead to kind of shorter and shorter durations of remission with each successive line of therapy. So there really is this impetus, I think, to go on to something different with immunotherapies or targeted agents. And in the second line setting, lenalidomide and rituximab has been previously approved. And I think that's where most people are typically inclined to move away from chemoimmunotherapy and bring that in. So I agree. I think that the data from InMind has the capacity to potentially be practice changing, where if you're going to be using lenalidomide and rituximab, based on the weight of the data and favorable efficacy and reasonable toxicity profile, that it may very well be the combination of tafasitamab, lenalidomide, and rituximab that now is the new standard moving forward. Beyond that, in the third line setting, right now we have bispecific antibodies approved. We have CAR T cell therapy approved. We didn't actually talk about some of the new data in CAR T cell therapy today, but there were some nice abstracts presented at ASH of the prior studies that had been already published looking at slightly longer term outcomes from CAR T cell therapy. I think it's fair to say that, it's too early to say that CAR T cell therapy could be curative for follicular lymphoma, but, some patients do obtain sustained benefit, but we know with the, counterpoint that it does involve logistical challenges, resource issues, and of course, some unique toxicities. I think in the clinical setting, bispecific antibodies are really becoming much more commonly used now in the third line setting and beyond, although, can be sometimes a challenge for people to deliver in community practices, but, it has been a learning curve bringing them into the clinic. But certainly it was exciting today to see some of the novel combinations moving forward. Many of them are based on immunotherapy platforms like lenalidomide and rituximab and showing very encouraging data. I think, the world's likely to get more complicated as more data comes out. Many of these combinations are now entering phase 3 trials, both in the second line setting and even the front line setting. So we may likely see a shift even moving forward with more data emerging. But I think, although some of this early data is exciting, we do really need to get more data in terms of more patients and then comparative data so that we understand the full implications of novel toxicities that might be seen as well.
Yeah, and I think that's a good point. And I would say that, that would be the next thing to kind of really highlight is potential safety concerns, right? So I do think it was nice to see some of these fixed duration schedules, because we know, with the bispecific antibodies, when they're continued until progression, that we can see more infectious toxicity the longer that patients are on them. You mentioned the schedule can be difficult, or it can be difficult to administer in the community due to logistics. But I think it was nice to see that fixed duration dosing of the bispecific antibody. And it kind of makes me wonder, of course, we need to look at durability, but if we're able to even bring that back more to even shorter duration of these therapies, and some of that may depend on in the future if we see retreatment data, can patients be retreated with these agents, then maybe we'll be able to even shorten durations more. I think that was also nice to see in the loncastuximab data that they plan to further expand that into a multi-center trial, but are considering maybe less doses, because in these patients, when you get very high response rates, very high complete response rates, and they at least appear to be durable remissions, it's nice to take into account, can we get the same outcomes with more fixed duration therapy to save our patients some of these toxicities?
Mm-hmm. Absolutely. I think what's going to be fascinating moving forward is really, with all this data emerging, there will be increasing choice both between patients and, their physicians. And I think it's going to be really much more important to have a discussion regarding patient preferences and what they prioritize as being most important for them, and what works best with, their circumstance and their lifestyle, given the different, sort of different schedules whereby some of these treatments are administered on. You mentioned, some of them go on for longer, some are now shorter. But I think, really bringing the patient into that discussion based on expectations of benefit, side effects, and what it means actually, for having this treatment with their lifestyle, I think is going to be more and more important. Well, thanks for your very thoughtful synopsis, Cami. And we're going to move forward into the next chapter, where I'll summarize the most impactful findings that we discussed, as well as highlight ongoing clinical trials of interest for the future. So moving forward, as we chart the course for management in patients with relapsed refractory follicular lymphoma, I'm going to discuss some key takeaways from ASH 2024, as well as some future directions. So today we discussed some of the select abstracts in relapsed refractory follicular lymphoma. And I think the one practice or potentially practice-changing trial was the InMind trial that basically showed an improvement in progression-free survival with the addition of tafasitamab to lenalidomide and rituximab, a commonly used immunotherapy in the relapsed refractory setting. But we know that there are lots of additional novel combinations being tested. We reviewed some of the updated data on bispecific antibodies combined also with lenalidomide and rituximab, showing real promise, and some longer-term follow-up showing some durable responses, as well as some novel agents like loncastuximab tesirine antibody drug conjugate combined with rituximab, showing some early data of efficacy. Also, we saw at ASH some additional data emerging on CAR T cell therapies, some longer term follow up of the anti CD19 CAR Ts showing durable benefit in patients. But also, we're starting to see data emerge of CAR T cell therapy for follicular lymphoma in the second line setting. So things are certainly moving fast. We saw some additional data looking at longer term follow up of mosunetuzumab, where bispecific antibodies now are commonly used in the third line setting as well. Moving forward, we're going to need to continue to digest, all of these options, and I think it's going to be important to present patients' management options as they evolve and discuss not only the potential benefits of treatment options that are available, but the relevant toxicities and also the implications for the patient in terms of administration schedules. But what we're certain of is that we're going to be having a lot more discussions as more and more data comes out, because there are numerous ongoing trials in relapsed refractory follicular lymphoma. Many of these novel combinations are starting to move forward into the second line and now first line setting with phase 3 trials, particularly phase 3 trials that are aiming to push out chemoimmunotherapy. So we're certainly excited about the data that's emerged from these immunotherapy combinations. And as they move forward and get tested in phase 3 trials in both second line and frontline settings, we may actually see a big shift in the paradigm of treatment moving forward as all of this data emerges. So with that, I'd like to thank Dr. Cami Maddox for joining me today and thinking through the data, but it certainly is an exciting time.
And thank you for having me.
And with that, I think we'll see you next year at ASH.
This program was presented by Medscape Education Global.